A 78-year-old woman came to my office with chronic jaw pain and a very concerning x-ray. Her primary care doctor was worried it might be cancer. What it turned out to be is something every professional and patient needs to know about. I'm Dr. Tom Bolton, board-certified oral and maxillofacial surgeon, and this is the open reduction. This case started with a referral. A primary care physician ordered a CT scan for a patient who had chronic jaw pain for several months. The results were alarming. Diffuse bony changes throughout the entire mandible. She was sent to my office for further evaluation. I could see immediately this woman was very frail. She displayed signs of cachexia, significant muscle wasting, and weight loss, which told me before I even examined her that her body was in a state of stress. I performed a thorough clinical exam and obtained a cone beam CT in the office. What I saw was striking. There were multiple destructive lesions throughout the mandible. The cortex, the hard outer layer of the mandible, was deteriorating in several locations. There were areas of dead bone that had separated from the living tissue around it, called sequestrum. With findings like this, there are two diagnoses at the top of the list. The first is metastatic disease, where cancer is spread from other areas of the body into the jaw. The second is a condition called medication-related osteonecrosis of the jaw, or MRONJ. I reviewed her medication list, and there it was. She is taking Prolia. Prolia, generically named denosumab, is a medication commonly prescribed to treat osteoporosis, particularly in older women. It's a very effective and widely used drug, but there is a serious and underappreciated side effect. In some patients, Prolia can prohibit the jaw's ability to heal itself. The jaw is unique among bones in the body. It's constantly subjected to the mechanical stress of chewing, and it has a rich blood supply that supports continuous remodeling. When that remodeling process is interrupted by medications like Prolia, the bone can begin to die. Slowly and silently. And by the time it's visible on imaging, the damage can be extensive. Even with the medication list, I can't definitively rule out metastatic disease without tissue. These two conditions can look very similar on imaging. The best way to establish a diagnosis is through a biopsy. In most cases, accessing the mandible surgically means going through the mouth. But given the distribution of her lesions, the most accessible and representative bone was actually on the lingual chin. I approached the mandible through a submental incision. When the pathology results came back, the diagnosis is confirmed: MRONJ. I'll be honest, this is a relief. But MRONJ in a patient like this is not a simple problem. Her lesions were diffuse, spanning almost the entire mandible. Not only that, her overall health is very fragile. This was not a case where I could simply remove the affected bone and reconstruct the jaw. In a patient this frail with this extent of disease, the treatment is conservative management. This means discontinuing Prolia, coordinating with her primary care physician to explore alternative treatments for her osteoporosis, maintaining meticulous oral hygiene, monitoring closely, and addressing with minimally invasive procedures when the patient develops significant pain. There's three things to take away with this case. First, if you're a clinician, always ask your patients about anti-resorptive medications. Prolia, bisphosphonates like Fosamax and Zometa. These are medications that can lead to MRONJ. A thorough medication history is essential. Second, metastatic cancer can be confused with MRONJ on imaging. Don't assume, biopsy. Third, aggressive surgery is not always the right answer. In the right clinical context, conservative management is a legitimate and appropriate option. Knowing when not to operate is just as important as knowing how to operate. This case is an excellent example of how important it is to look at the entire clinical picture before treatment planning, coordinating with other medical teams, and understanding that sometimes conservative management is the best option. I'm Dr. Tom Bolton. I'll catch you next time on the Open Reduction.